Hi, everyone. Welcome to this edition of Family Medicine on Air. Thanks for joining us. I'm Sam Carlson of the AAFP, and I'd like to go over one housekeeping item before we get started. For those of you using Google+, feel free to use the Q&A feature to submit questions during the Hangout, and we'll do our best to get to them at the end. And now I'd like to introduce our host for this episode, Cleveland Piggott. Cleveland is a fourth-year medical student at the University of North Carolina and the FMIG Network Region 4 Coordinator. Cleveland, take it away.
Welcome to Family Medicine on Air. The American Academy of Family Physicians and the Family Medicine Interest Group Network bring you this live social media series to give medical students across the country a chance to learn about hot topics in healthcare directly from leaders in family medicine. In addition to today's live broadcast, this video will be archived in the FMIG Network's YouTube channel, and we have some additional resources and information we'll share with you in a little bit. Today's episode is titled, What Medical Students Need to Know About Direct Primary Care. Here to tell us more about it is Dr. Reed Blackwelder. Dr. Blackwelder is a family physician from Kingsport, Tennessee, and is the current board chair of the American Academy of Family Physicians. In his daily life, Dr. Blackwelder is an educator. He is Director of Medical Student Education Division of the Department of Family Medicine at the James H. Quillen College of Medicine at East Tennessee State University and spends his days in the clinic with patients, precepting, and teaching both residents and students. I'll turn things over to Dr. Blackwelder to tell us what medical students need to know about direct primary care, and then I'll come back with a few questions submitted by your fellow medical students. Dr. Blackwelder?
Thank you, Cleveland. I really appreciate the chance to be here to talk to students and especially student leaders about this exciting new way of delivering medical care to our patients, and also it's part of a new way of helping to pay for medical care. This is really important because in medical school we really emphasize in the first 2 years the basic sciences, then you go on clerkships and we have creative electives. All of these are critical toward preparing you to begin to take care of your patients. However, there's another critical aspect that we don't do as good a job on, either in medical school or in residency, and that's in teaching the practice management components and, in fact, going over the different models of practice styles that are available for students and residents. So this is a great opportunity to come up with some resources and to help everybody begin to decide how they might want to practice medicine. Before we start talking about it, I did want to recognize that this entire topic demonstrates one of the key aspects of the AAFP and the Board of Directors. Part of our job is to create value for membership, and it's to be aware of trends and processes that are going on in our practice. And some years ago, we noticed there were a couple of members who were beginning to practice in a different way. And we paid attention, we surveyed our members, and we discovered in the past year or so that even though the percentage of our members who were actually actively practicing direct primary care was small, the interest was accelerating rather dramatically. So accordingly, about a year ago, we began to put some emphasis into developing the resources that we'll talk about today, but also in highlighting some of the opportunities. And we've had several workshops discussing this particular topic. We've worked with members who have been involved in it, and we're finding ways of ensuring that this is at least a model that people can find out about. And I appreciate this being an opportunity to share some of these thoughts as well. So as we get started, I did want to go ahead and talk about a couple of different key aspects, maybe 2 or 3 items before we get to the questions. One of them really is about the term, and words are extremely important. And you'll hear the word direct primary care, and a lot of times you might hear concierge medicine mentioned at the same time. And actually the words are different and they refer to different kinds of practice, and it's extremely important that we're clear about that up front. The concierge practice is really the sort of traditional and an original way of working directly with patients, but in the fee-for-service environment. This is really a way of creating a connection with patients between a physician and their practice, but it involves an additional fee that is then added to by fee-for-service or regular billing for other services. So some of the routine interactions between the physician and the patient will still generate a charge, and this charge is through the regular fee-for-service model. And the fee-for-service basically allows you to then submit a charge. However, in concierge medicine, those services, which we often may see as sort of routine care that we provide in the office, are seen as sort of an ancillary service, something done in addition to the fee that's charged. The challenge for that is it really has been limited often to people who have certain financial resources and are able to create that connection. Direct primary care, on the other hand, really came out of several members who were looking at a different way of practicing medicine for patients who were underserved, who didn't have access to care. And it was a way of really contracting directly with the patient in order to provide many of the services. So one of the things that happens in this regard is that there is a shift away from the fee-for-service model, and it's really shifting more toward what the patient needs at that time. And so the membership fee for that connection creates an opportunity to pay for a lot of what right now is routine care that we provide that is not face-to-face. It's often called asynchronous care. So I may be managing a patient in the hospital. I'll look at all the records, I'll call the consultant, I'll take care of some medications, I'll ensure that home health is arranged. And in the current fee-for-service model, that care, which is provided non-face-to-face, can't be billed or paid for. With direct primary care, because of the membership fee and that connection with my practice, I'm able to do that, I'm able to provide the care, but then I'm able to maximize the face-to-face time. So it's important to see those differences because there are substantial differences in how that we interact with our patients and how who actually has access to those services. There's another key component about primary care is why would a physician, a medical student, a resident, or even a patient consider a direct primary care model? One of the real challenges right now, and we've mentioned it already, is the fee-for-service. This really is a pay-for-volume system, and it creates the hamster wheel. It creates that need to bring people in regularly to provide care, which is necessary, but in order to submit a bill, you have to have the patient in the office. And this is extremely frustrating for everybody, and it's led to some significant challenges in our country, and one reason we needed healthcare reform. We have to move away from that fee-for-service model. That model creates short visits. We've all heard of the 15-minute visit with only 18 seconds spent asking for the patient's perspective of history. It creates a tendency to do things in order to get billing. It frustrates everybody. And in many ways, the documentation that we have to do is what we call bullets for billing. We're documenting for the billing services and not so much for the patient care. So what happens with direct primary care is because of that direct relationship with the patient, the visits change, the care changes. We are now basically documenting in order to support patient outcomes. And in fact, we're starting to see early data that direct primary care can actually improve patient outcomes, definitely improves the satisfaction of patients in the system, definitely improves the satisfaction of the providers in the system, and does so at lower cost. This is really something that is critically important, and we call this the quadruple aim. This is a very important aspect of why we needed healthcare reform in this country. So with this in mind, I think you can see why, with the satisfaction involved and the opportunity for longer visits that really allow us to work with our patients and to see patients for those things that they need to be seen for, can create a very significant impact and a reason to consider that as a potential model. I think the third component of this, it relates to the question of the smaller panels. And there's been some anxiety raised because when you're looking at a direct primary care practice, the number of patients that are actually in those panels is smaller, and this creates a concern about the potential for meeting the patient care needs in this country. Well, one of the things that I think is important is we absolutely have to address the pipeline issues. We have to find ways of getting more medical students to choose family medicine. But one way to do that is to incentivize primary care, to incentivize family medicine. Direct primary care does that by making the relationship with the patient the focus, by giving patients and physicians more time in those visits, to let us do what we're trained to do, to let us do patient care as opposed to chart care, which is currently required for billing, will truly make it more likely that students will say, this is what I want to do, this is how I want to practice medicine. So in many ways, over time, having models like this that emphasize the relationship and emphasize the quadruple aim, I think will help to drive medical students and residents into primary care and into family medicine, and therefore as we have more family physicians, we can more readily meet the needs of our patients. So Cleveland, those are three of the items I wanted to get out and talk about, but I know you had some questions that you wanted to go through as well. So let me turn it back to you and let's hear what people are curious about.
Thanks, Dr. Blackwelder. That was really informative. I do have a few questions that were submitted by students through their FMIG Network Regional Coordinator. The first question is, where has this model been shown to be successful, and what are common reasons direct primary care practices succeed or fail?
Great question. It's important to recognize this is still early, and at least in some ways. Now, there are a couple of places in this country where there is a direct primary care model that's actually been in practice for some time, and we're seeing some of the outcomes data that supports what I said before about the quadruple aim. So in Washington and Texas, and then I know a family physician in North Carolina that has done an outstanding job. One of the keys to success is not necessarily the location, because these have come up in rural areas and in rural areas and in underserved areas. It really is about the business model, and it really requires attention to putting everything into place to know how you're going to set up your practice if you're starting a practice from scratch. And you need to follow some clear processes. This is one of the things that we have available as far as our resources for folks who are interested in this. So definitely want to go to the website and look at the business plan and look at some of the proposed aspects. The times that it has failed is when people have not put the work in ahead of time, have not asked the right questions and done the needs assessment for the community, or haven't given it enough time. It can take 18 to 24 months to make this change, especially if you're going to do a hybrid model where you're transitioning from a regular practice.
Okay. How about, as a medical student, I go on lots of interviews, and a lot of people haven't heard about direct primary care, and where can we learn about direct primary care and new models of care?
Well, as we've referred to a couple of times, this is a great time to say, come see us. One of the values of membership is on the AFP website, and of course, many of our viewers are already members. But 1 in 4 medical students are members of the AFP, and we'd like to see even more. We have many resources immediately available there, including a direct primary care toolkit. We have frequently asked questions, and we have, as an academy, sponsored several workshops. One is at our annual conference of chapter leaders that we're now having every April. We had a great pathway at our recent annual assembly, which will be called FMX in the future. So we have some tremendous resources available right now to help people move through this model.
What can direct primary care practices do about, can they see people with insurance, and how about serving people who are very poor and can't pay the retainer fee?
Absolutely great question. This can actually serve many patients. Patients with insurance can come to a direct primary care practice and be seen. They will then submit the bills themselves to their insurance companies. In fact, some patients with Medicare use direct primary care. So there are many ways that this can happen. Now, it's important to recognize that it is, you need to have what's called wraparound insurance for those catastrophic times that you might need to be in the hospital or have something happen, because direct primary care is basically the relationship between the patient and the physician at that time. So having some way of paying for those emergencies and catastrophes is important. But one model that I know, a physician went into an area where half of the patients there had no insurance, and he was able to immediately provide services for those patients, improve their outcomes, create an access they've never had before. So this model can work in many different environments.
That's great. And one last question. How do direct primary care providers supply affordable medications, imaging, etc. to their patients?
Very important question, another exciting advantage. Many of the direct primary care providers have been able to negotiate very steep cash discounts with pharmacies, with hospitals, with radiology departments. So because of that cash basis, they're able to get significant discounts for their patients because they pay up front. Also, a lot of direct primary care will contract to provide generic medications at significant cost savings and really just provide these services at cost to their patients. So this is a way of saving money all throughout the system.
That's great, and thank you so much, Dr. Blackwelder.
Well, you're welcome.
If you guys would like to learn more about direct primary care, head to the aafp.org/FM on air. There you'll find a handout on physician payment reform and direct primary care discussion questions, frequently asked questions, and other resources. We also hope you'll join us for the next episode of Family Medicine on Air this February, when we'll have AAFP President Dr. Robert Wergen present on cost of care. Thank you again, Dr. Blackwelder, for being today's featured speaker.
Thank you, Cleveland.
And thanks everyone for listening in.